Hello, I'm Dr. Hamid Davidson, Professor of Medicine in the Division of Endocrinology, Diabetes and Metabolism, and the Touchstone Diabetes Research Center at the University of Texas Southwestern Medical Center. Thank you for joining us for this CME-CE webcast focusing on type 2 diabetes treatment, novel therapies, GLP-1 receptor agonists, analogs, and DPP-4 inhibitors. We have known that there are major therapeutic targets in type 2 diabetes, and for many years we have actually insulin replacement, we have sulfonylureas that increase insulin secretion, and then we have agglutinides that do the same thing, and then we have sensitizers like metformin and thiazolidinediones. In the last several years, we have a significant increase in different therapeutic areas. For example, we have now the incretin families, GLP-1 agonists, DPP-4 inhibitors, and most recently, therapies that actually target the kidney, called SGLT2 inhibitors that actually prevent glucose reabsorption. In this slide, you see all the actions of these different agents. The reason we still look for new agents is because we have limitations in the older agents that we use to treat type 2 diabetes. Limitations such as hypoglycemia. When we talk about hypoglycemia, we know there's a significant increase when we use secretagogues and insulin. When we have weight gain undesirable in type 2 diabetes, we can talk about secretagogues, glitazones, and insulin. When we talk about edema, peripheral edema, glitazones, and insulin. GI side effects, metformin, alpha-glucosidase inhibitors. Lactic acidosis, even though it is rare, it can happen with metformin. We also have safety issues in elderly, in renally impaired, or in patients with a history of congestive heart failure. These agents are glitazones and sulfonylureas. Poor response rates, all oral medications. And finally, the lack of durable effects. All oral monotherapy, except glitazones, have a very short duration of effect. Function of incretins in healthy individuals. Role of incretins in glucose homeostasis. In real life, when we actually eat, we release gut hormones even before we eat just by seeing food. And we have active GLP-1 and GIP. We have actually important actions, glucose-dependent increased insulin from beta cells by GLP-1 and GIP. That means that we're going to have an increase in insulin, but when the glucose is getting closer to normal in the low levels, that insulin secretion stops. So it's an intelligent way of lowering glucose. And there's also glucose-dependent decreased glucagon from alpha cells, so that with these drugs, we maintain the insulin glucagon so patients will not have hypoglycemia. Indirectly, we have increased glucose uptake by muscles and decreased glucose production by the liver. We have two ways, of doing this. One is by giving a GLP-1, and another one is by giving a DPP-4 inhibitor. And we'll talk a little more about this in a few minutes. What are the actions of GLP-1? Stimulation of insulin secretion, glucose-dependent. Inhibition of glucagon secretion, glucose-dependent. Reduction in circulating glucose, delaying gastric emptying. Induction of satiety and reduction of food intake. Potentially improve myocardial and endothelial function seen in animal data, and possible neuroprotection. So these drugs have a lot more to offer than just glucose centricity. DPP-4 inhibitors. Transmembrane cell surface aminopeptidase expressed in liver, lungs, kidneys, intestines, lymphocytes, and endothelial cells. There's an active extracellular domain, also circulates as free soluble DPP-4 in plasma. Their active site is in a large pocket. Access is limited to substrates with small side change. As an example, proline and alanine. This active site cleaves to proline or alanine from second amino terminal position, inactivating its substrates. And the key substrates are GLP-1 and GIP. Then there's a rapid and efficient metabolism by DPP4 that makes the half-life of GLP-1 very short. Then when we inhibit these DPP4s, we made the half-life of GLP-1, of natural GLP-1, much longer. Incretin dysfunction in type 2 diabetes. We have known for a long time that there is an incretin effect. When people receive insulin, an oral glucose load versus an intravenous glucose infusion, the action of insulin is totally different. When we give an oral glucose load or when we eat, insulin secretion is significantly higher than when we give an intravenous glucose infusion. And that's what we call the incretin effect. In patients with type 2 diabetes, this incretin effect is significantly diminished. And that's why in real life we see a failure of insulin secretion in the first phase. And that's what we call the incretin effect, the difference between the insulin secretion after an oral glucose load, which is higher, versus an intravenous glucose infusion, which is much lower. And that, in patients with type 2 diabetes, is impaired. We also have data, sometimes data is confusing, but we have data from Tove Nielsen in the Journal of Clinical Endocrinology and Metabolism, showing that postprandial GLP-1 levels in patients with intolerance and type 2 diabetes are significantly decreased. Normal glucose tolerance is higher. When we have a patient with impaired glucose tolerance is lower, and we have a patient with type 2 diabetes even lower than before. And you can see that very clearly in this slide. There's two strategies for GLP-1 enhancement. How can we enhance GLP-1? Well, we can actually administer a GLP-1 analog. These are chemically modified GLP-1, not susceptible to DPP4 metabolism. So these agents have a longer half-life and a higher GLP-1 level. FDA approved exenatide BID, exenatide once weekly, and liraglutide, and some new ones in the foreseeable future, like albiglutide, lixacenatide, and dulaglutide. All these agents have to be given as an injection into the subcutaneous tissue. DPP4 inhibitors block the DPP4 so that it blunts the breakdown of GLP-1. It raises endogenous GLP-1 levels and also GIP. Remember what I told you before. Without that, the DPP4 enzyme degrades GLP-1 in a very short period of time of less than 2 minutes. With these drugs, we enhance the GLP-1 levels and the time of action. FDA approved alogliptin, linagliptin, saxagliptin, and sitagliptin, and vildagliptin has been approved outside the U.S. There may be other DPP4s in the foreseeable future. The advantage is these are oral administration. We already talked about the mode of action of the DPP4 inhibitors. And again, if you remember, this enzyme inactivates GLP-1 very quickly. Then if we inhibit the DPP4, we actually augment glucose-dependent insulin secretion, we inhibit glucagon secretion and hepatic glucose production, and we improve hyperglycemia. This is a selective inhibition of DPP4 that increases plasma GLP-1 levels, resulting in the reduction of glucose levels. DPP4 inhibition improves GLP-1 levels. There are several studies, in this particular one, with sitagliptin 25 and sitagliptin 200. In an oral glucose tolerance test, we see a significant increase of active GLP-1 compared to placebo, where the placebo increases in picomoles about 7 picomoles at 2 hours to 3 hours. The use of sitagliptin increases it between 15 and 20 with the 25 and 200 milligram dose, and it remains higher for about 6 hours. Linagliptin has also a very nice effect on GLP-1 and on glucagon. In this particular study, there's significantly statistically difference in postprandial intact GLP-1, which increases, and glucagon that decreases versus placebo after 4 weeks of treatment in patients with type 2 diabetes. Then in the left-hand side, you see the nice increase in GLP-1, and in the right-hand side, you see the nice decrease in glucagon, and this is at day 28, and this is after the administration. And you look in hours, the biggest effect is in 1.5 hours, and it continues for the duration of the study, in this study actually 3 hours. Now we're moving to the therapeutic effect of GLP-1 in patients with type 2 diabetes. In this particular study, 10 patients, fully controlled with type 2 diabetes, received infusions of GLP-1 or placebo. And what we saw is that with the GLP-1, we saw a significantly increased insulin, 17.4 nanomoles, and the C-peptide increased 228 nanomoles. The GLP-1 significantly reduced the fasting plasma glucose. Actually, in this particular study, because it's an infusion, normal levels were reached in all patients. The pancreatic glucagon secretion was decreased by 1,418 picomoles per 1 per minute, and the plasma non-serified fatty acids were decreased by 26.3 millimoles also per minute. Now we're moving into GLP-1 receptor agonists and DPP-4 inhibitors, and we're going to show the effects on A1C, glucose, and insulin levels. We're going now to talk about exenatide and the beneficial effects on fasting plasma glucose and insulin in patients with type 2 diabetes. In blue, you have placebo, and in the different shades of pink to purple, you have exenatide at a low dose, and the darker it is exenatide at a higher dose. When you look at mean fasting plasma glucose, you're seeing that there is a significant improvement in 3 and 4 hours post-dose, and the most important is the 4 hours post-dose is actually close to normal with the 0.1 and 0.2 micrograms per kilo. In the right-hand side, what you see is the peak mean incremental serum insulin, so that patients, actually have a nice increase in insulin secretion. When we look at the next study from Coulterman in 2003, what you see here with exenatide twice daily is the beneficial effects on both postprandial glucose and glucagon in patients with type 2 diabetes. And this is exenatide at 0.1 micrograms per kilo. And you see that there is a significant improvement in postprandial glucose by day 5 compared to placebo. Now we're moving to 3 years of therapy with this GLP-1 called exenatide. This study shows 217 patients randomized to placebo, 5 micrograms of exenatide or 10 micrograms of exenatide during a prior 30-week placebo-controlled studies, and were transitioned to open-label exenatide treatment. All patients had a minimum of 3 years of exenatide exposure for this analysis. By week 12, exenatide reduced the A1C by 1.1%. This reduction in A1C was sustained throughout 156 weeks of treatment. The change from baseline to week 156 was minus 1%, and 46% of patients achieved the A1C of below 7% or equal to 7%, and 30% achieved the ACE goals of an A1C of 6.5% or below. So what we can see is these agents are very efficient. Now let's move to the second GLP-1 that has been approved in the United States and the world. It's called liraglutide, and this particular study was 1 year monotherapy and showed the reduction in fasting plasma glucose and postprandial. The longer a GLP-1 agent is, analog, the better lowering of the fasting you're going to see. The shorter, you're going to see probably a better reduction in postprandial. Then exenatide twice daily, has a little better lowering of postprandial, but liraglutide has a much better lowering on the fasting. And this is compared with glimepiride, a secretagogue of the sulfonylurea families. And you can see here that the lowering of the fasting by glimepiride is 5.2 milligrams per deciliter. Lira at the 1.2 milligram dose is 15 milligrams, and the 1.8 dose is 25.6 milligrams lowering, statistically significant. And the postprandial, glimepiride lowers 24.5, the low dose of Lira at 1.2 30.8, and the one dose of 1.8 37.5. Again, superior, in the 1.8 dose. And again, these are agents that are very powerful. Liraglutide 1-year monotherapy and the effects on glucose control. Here you have glimepiride with 248 patients, liraglutide 1.2 with 251, and liraglutide 1.8 with 246 patients. And you can see that the 1.2 milligram dose of liraglutide is superior to glimepiride. And in this particular study, the difference is 0.51 for glimepiride and 0.84 for the 1.2 milligrams of liraglutide. In this study, the large dose of liraglutide, the highest dose approved of 1.8 for diabetes, is more than double in the lowering of A1C than glimepiride. In this slide, you see the study of liraglutide and glimepiride, but now over a 2-year period, and actually divided by disease duration of less than 3 years or more than 3 years. And what is important to know is the sooner that we intervene, the more effective any of these agents are. And if the duration of disease was less than 3 years, liraglutide 1.8 decreased the A1C by 1.4 and glimepiride by 0.7. If the patient had 3 years or more of diabetes duration, the effect of lira went down from 1.4 to 1, and the effect on glimepiride from 0.7 to 0.4. Again, the other significant difference in the studies is weight. There was an increase of 1 kilo, 0.1 with glimepiride, and there was a decrease of 2.7 kilos with liraglutide. Then you achieve better glycemic control without hypoglycemia and some weight loss. Now we go to the next GLP-1 that has been approved and is exenatide once weekly. And in this particular study, is exenatide once weekly versus exenatide twice daily on glycemic control. Remember, exenatide once weekly has a very long duration of action. So you can see here that the 10 micrograms twice daily versus exenatide 2 milligrams once weekly has a very nice effect on A1C, 1.5 for the BID and 1.9 for the once weekly. The number of patients in percentage that achieve an A1C below 7 is quite good for both, 61% for exenatide twice daily and 77% for exenatide once weekly. And you can see the difference in fasting. Once you have a long-acting GLP-1, as I told you before, you're going to have a better effect on the fasting. And you see it here, 25 milligrams per deciliter with exenatide twice daily versus 41 with exenatide presentation of once weekly. And we see that the incidence of nausea was 35 with exenatide BID and lower with exenatide once weekly, 35 versus 26%. The weight loss was similar, about 4 kilos in both groups. And as you know, mechanistically, unless you use sulfonylureas of insulin, these drugs are very safe for hypoglycemia, but minor rates of hypoglycemia were seen, 6.1% in the exenatide BID and 5.4 in the once weekly. This is the final study with exenatide once weekly versus exenatide BID, and what you see here in this Tom Blevins article in the Journal of Clinical Endocrinology and Metabolism is that you can lower the A1C 1.6 with once weekly and 0.9 with BID. And again, these are studies, and every patient is an individual, and they may have different responses to different drugs, including GLP-1s and DPP-4s. The nice thing about these agents is durability. And in this particular study, you can see that, the study at 26 weeks has durability. At 26 weeks, it's an open-label study, and patients were switched from sitagliptin in green to exenatide in purple. And at the end of the 52 weeks, there's durability for both, and those patients that were in sitagliptin were able to lower the A1C further than they were on sitagliptin. So again, a GLP-1 seems to be a little more powerful than a DPP-4 inhibitor. This is the study, exenatide once weekly, and the percent of patients to go compared to a DPP-4 inhibitor, in this case sitagliptin, and or pioglitazone. And exenatide once weekly, 63% of the patients were able to reach an A1C of less than 7, sitagliptin 43%, and pioglitazone 61%, an A1C below 6.5 or equal to 6.5, almost 50% with exenatide once weekly, 25% with sitagliptin, and 42% with pioglitazone. These patients have a metformin background, and we know from this study that a lot more patients were able to reach the goals of 7 and 6.5 with exenatide than with a DPP-4. Now let's take an overview of GLP-1 receptor agonist safety data. Hypoglycemia is very rare, but is higher when you combine with sulfonylureas. Cardiovascular events appear to be very safe. Nausea is increased, more with exenatide BID than liraglutide. And there is also a small percentage of vomiting and a small percentage of diarrhea. This is the molecule of different and current approved DPP-4 inhibitors. Sitagliptin, saxagliptin, alogliptin, and linagliptin, all approved in the U.S., and vildagliptin that has been approved outside the U.S. but not in the U.S. Then when we look at all these DPP-4s and we look at the efficacy, if we look at alogliptin, we look at linagliptin, and then at saxagliptin, and sitagliptin, and vildagliptin, we see that there are minor differences. The difference may be 0.1. So they are very, very good agents, but they're limited to about 0.6 to 0.7 in the lower of the A1C. And here you can see the basal A1C and the doses of the different agents. You need to remember that with linagliptin, if the patients have any degree of renal insufficiency, you don't need to titrate the dose down. With the rest of these agents, you have to. All these agents can be given once daily, with the exception of vildagliptin that is not available in the U.S., that has to be given twice daily. The latest DPP-4 approved in the U.S. is alogliptin, and here you have phase 3 trials, and this is the A1C change from baseline after 26 weeks. And again, you can see that in monotherapy, if we look at 12.5 and 25, there's a slight difference, but in both doses, you can reach 0.5% lowering of the A1C and almost 0.6 with a higher dose of 25 compared with placebo that did not do any significant changes in the A1C at that point. Add-on therapy to SUs, to metformin, to pioglitazone, and to insulin. And what you can see is that you actually improve A1C with a low dose of 12.5, added to SUs 0.39, added to metformin very nicely 0.6, added to PO very nice as well 0.66, and to insulin 0.63. The high dose improves with SUs to 0.53, stays the same when added to metformin, much better when added to pioglitazone 0.8, and also much better when added to insulin 0.71. So these agents can be combined with different oral agents and still improve glucose control. Now we're moving to linagliptin that significantly reduced A1C after 24 weeks in patients on stable insulin dose. In many patients with type 2 diabetes, we have no other alternative than to use insulin if the patient is poorly controlled on 1 or 2 or 3 oral agents. In this particular study, linagliptin was added to patients on insulin. One group remained on placebo instead of active agent, and you can see that, unfortunately, the natural history of diabetes continues. There's a slight increase of A1C at 24 weeks. When we use the linagliptin, the improvement is 0.58, and when it's placebo-corrected, it's 0.65. Then, again, we see a very nice effect of glucose lowering in patients with type 2 diabetes treated with insulin, not at control. As we all know, people 65 and older are actually contributing to one of the significant increases in type 2 diabetes in the world. And we need to know what happens when you get to be older than that. And in this particular study, linagliptin was studied in patients over the age of 75. This is a pre-specified subgroup analysis. There was no significant interaction according to patient age group. The study had a high proportion of elderly patients. 65 to 74 was 26.1% for linagliptin and 28.7% for placebo. And patients 75 years and older, 5.5% for linagliptin, 6.5% for placebo. We can use safely this drug in elderly people. And you can see here what happened in this particular study in patients for 52-week free insulin titration period. You can see that there was a stable insulin dose from baseline to week 24 and free insulin dose starting at week 24. And you can see what happens at week 52. And there's always a positive lowering of A1C when you use linagliptin, even though you are actually titrating insulin between week 24 and week 52. This is again linagliptin showing a significant reduction in fasting plasma glucose after 24 weeks and maintained for 28-week free insulin titration period. It's the same study of icajavanin published in Diabetes Care in 2013. From the same study, we're going to see the insulin dose that was stabilized in first 24 weeks and increased in both groups in the second 28-week free titration period with greater extent in the placebo group. Then you can see insulin stable until week 24, very little adjustment, but from week 24 to the end of the study, you can see that people on placebo had to increase the insulin 4.2 units versus 2.6 only in the linagliptin group. We go now to safety, and this is the safety profile of linagliptin compared with placebo after 52 weeks of therapy. The N was 631 for linagliptin and 630 patients for placebo. As you know, when we report any adverse events, we report upper respiratory infection, earaches, anything that happens. So you can see that the reporting is high. It's 78.4 for linagliptin, 81.4 for placebo. When the investigators defined drug-related adverse events, they were 18.7% with linagliptin and a little higher in the placebo group of 22.2% with placebo. Remember, these studies are blinded for the investigator. Patients with adverse events leading to discontinuation of trial drug, 3.3% for linagliptin and 4.4% with placebo. Essentially, there's really no significant difference in adverse events for patients taking linagliptin or patients taking placebo. Same is true with serious adverse events, 13.8 versus 13.2. Then, giving this drug to patients appear to be safe. We don't get so many colds. The tolerability with linagliptin appears to be very good. Our concern when we use any drug with insulin is hypoglycemia. And what we see here is hypoglycemia risk at 24 weeks and 52 weeks. And what we see here is that adding linagliptin, we see improved glycemic control when added to insulin, but it did not appear to increase the risk of hypoglycemia. At week 22, 23% of patients had hypoglycemia with placebo, 22% had hypoglycemia with linagliptin. At week 52, when the titration started, 33% of patients with placebo had hypoglycemic symptoms and 31% with linagliptin. So actually, there's not any increase in hypoglycemia when using linagliptin and insulin versus placebo. And this is just to confirm that the rates of hypoglycemia were similar to placebo, and the majority of hypoglycemia is non-severe. Most of the hypoglycemia was documented at below 72 and less than 9% below 55, 54, and severe was actually 0.6 and 0.3. So really no severe hypoglycemia should be expected in this combination. Then to summarize the study from Iki Jarvanen on linagliptin as add-on to insulin, efficacy and safety of linagliptin as add-on therapy to insulin in type 2 diabetes. Linagliptin significantly reduced the A1C after 24 weeks in patients on a stable insulin dose. Placebo-corrected reduction was minus 0.65%. The efficacy of linagliptin was reliable in different pre-specified subgroups, like elderly patients, 75 and older, like different categories of renal function. Also, A1C reductions were maintained over 52 weeks. Linagliptin significantly reduced fasting glucose after 24 weeks and maintained in 28-week free insulin titration period. Linagliptin, based on this study, has a safety profile comparable with placebo. Incidence of hypoglycemia with linagliptin was comparable with placebo. So this DPP-4 linagliptin appears to be efficacious and safe in patients with type 2 diabetes. In this particular study, add-on to insulin, but in every study we have seen. Now is looking at sitagliptin and santagliptin and A1C reductions. And this is in the left-hand side sitagliptin subgroup with a baseline A1C greater than 9%. And that was my point before. The higher the A1C, the better all these drugs will perform lowering glycemia. Doesn't mean it gets you to target, because here with a base of 9%, you lower the A1C with sitagliptin 50 q-day 1.15 and with 100 1.18. In the open label saxagliptin in 66 patients with a baseline A1C above 10 but equal or lower than 12, the decrease was even better at 1.87%. So if you're 10.5, you can go down to about 8.5. If we look at incretin-based therapies, there is improved glycemic control when used in combination. For example, exenatide add-on to metformin or to TZDs or to SUs. Same is true for liraglutide. Alogliptin with metformin initial therapy, add to metformin, add to TZDs, add to sulfonylurea. And the same is true for linagliptin, sitagliptin, and saxagliptin, and you have all the references there. So these therapies can be used with most of the existing therapeutic agents we have to improve glycemic control and safely. Now we're going to move to GLP-1, and this is exenatide once weekly, and this is the A1C reductions compared to sitagliptin or pioglitazone. And again, you know the data very well, and you see the baseline A1C with a diet and exercise background of 8.5. Exenatide lower the A1C 1.5, sitagliptin 1.2, which is very good for DPP-4, and that tells you every study is different, and with pioglitazone 1.63. When there was a metformin background, actually exenatide did better than sitagliptin and than pioglitazone. In this case, it maintained the lowering of the A1C at 1.5. Here, the lowering by a DPP-4 went down from 1.2 to 0.9, and the lowering with pioglitazone from 1.63 to 1.2. Again, you can see all these agents are really good in lowering glycemia, and it depends on your patient's individual needs which agent needs to be used. At the end of the day, we need to learn how to use all these agents in combination. In this slide, you're going to see fasting plasma glucose between exenatide once weekly, sitagliptin, and pioglitazone. In the left-hand side is diet and exercise background, and again, you see a nice reduction of fasting with pioglitazone, the most important one, followed by exenatide and followed by sitagliptin. The difference, 46, almost 47 with pio, 41 with exenatide, and only 20 with sitagliptin. In a metformin background, exenatide was much better at lowering the fasting, 32 milligrams, versus 27 of pio versus 16 with sitagliptin. Now we're going to move to the effect of these agents on weight. Why is weight a concern? That's the first question we ask. Most patients with type 2 diabetes are overweight and obese. And if you see an Asian patient that may have a BMI of 26, for them, that is obesity. So you need to look at race and ethnicity and some of the currently available therapies cause weight gain, secretagogues, glitazones, and insulin. Then when we look at exenatide in the open-label extension study, there's a continuous loss of body weight. In this particular study in kilos, at week 12, the weight loss 1.6. At week 156, the weight loss was over 5 kilos. And based on the baseline BMI, the bigger these people, the more weight they lose. If the BMI was below 30, the weight loss is 4 kilos. If the BMI is 30 or higher, the weight loss is almost 6 kilos. Is exenatide once weekly, and this is in weight reduction compared to sitagliptin or pioglitazone. So again, you're going to see here the difference, the secondary differences among this age. With exenatide weekly, there's weight loss on a diet and exercise background of 2 kilos. With a DPP4, in this case sitagliptin, 0.8 kilos. And with pioglitazone, there's an increase of 1.5 kilos. When there's a metformin background, exenatide and sitagliptin remain almost the same. There's 2.3 kilos weight loss with exenatide, 0.8 with sitagliptin, and now there's a slight increase in body weight when we use pioglitazone. In this particular case, the weight gain was almost 3 kilos. So those are the things you need to look when treating your patients. In this slide, we see the effect of liraglutide versus standard therapy on body weight. And you see Lirac 1.2, 1.8 with the comparator. Monotherapy, 2 to 3 weight loss, 1.8, 2 to 3, and a gain of 1 to 2 kilos in the glimepiride group. Add on to metformin, you see a weight loss of 2.6, 2.8 with Lirac 1.8, and a loss with placebo, but a gain of 1 kilo with glimepiride. Add on to SUs, the weight is neutral, 0.3, 0.2, and when you use placebo and rosiglitazone, the weight gain is 2.1 kilos. Then we move to the add-on to metformin plus a TZD, and here you see that we can lose weight when you have liraglutide 1.2, better weight loss with liraglutide 1.8 of 2, but when you use glimepiride, there's an increase of weight of 0.6 kilos. And the final study is add-on to metformin plus SUs, and the dose study here was 1.2, and there's a weight loss of 1.8 kilos compared with a gain weight with Largin of 1.6 kilos, and with placebo or a loss of 0.4 kilos. So again, anytime you see GLP-1 study, you're going to actually see improvement in weight loss versus anything else you study. The delay of gastric emptying. This is a study by Horowitz in 2012 in diabetes research and clinical practice. In this particular study is a comparative trial of liraglutide, glimepiride, and placebo in patients with type 2 diabetes, and the N is 46. Gastric emptying was slow with liraglutide mainly during the first postprandial hour. The mean estimated acetaminophen AUC from 0 to 60-minute ratio was 0.62 with liraglutide versus placebo and 0.67 with liraglutide versus glimepiride. Again, if we look at this, there is a better chance of improving gastric emptying with liraglutide at GLP-1 than with a placebo or glimepiride. How about the effect of body weight on DPP inhibitors? And you saw some of the studies, there is minimal weight loss, at least there's no weight gain. So these drugs are known to be weight neutral. And we're going to see here some of the data, the effect of allogliptin monotherapy in body weight versus placebo, and there is 0.22 kilos less with allogliptin 25, 0.09 with 12.5, and an increase of 0.18 versus placebo. Then again, it's weight neutral with a slight decrease of body weight, statistically not significant. The effect of body weight when added on to insulin, and this is terrific because what you see here is that we may actually have weight neutral, but a slight decrease in body weight when we add linagliptin to insulin. And this is at week 24 and at week 52. Now we're going to move into GLP-1 receptor agonists and DPP-4 inhibitors and the effect on lipids. Exenatide has beneficial effect on lipids. This was the first GLP-1, the first incretin therapy study, and it shows nicely a decrease in triglycerides, a decrease in total cholesterol, a nice increase in HDL, and a nice decrease in LDL, and this is actually in milligrams per deciliter. So all the lipid profile goes in the right direction, the way we like to see it in patients with type 2 diabetes. The next slide, this is the effect of exenatide once weekly and BID on lipids. We see, again in this particular study, that with exenatide once weekly, we see a better improvement on LDL. Both drugs will increase the HDL, but better with exenatide once weekly. Triglycerides will go down nicely with both in similar manner. VLDL goes down with both. Actually, if you look here, also very similar once weekly versus BID. And the non-HDL actually goes down 3.32 milligrams per deciliter with exenatide once weekly, and it doesn't have an effect with exenatide BID. Next slide is LIRA and the effect on triglycerides and cardiovascular inflammatory biomarkers. And you can see here the difference from placebo in change from baseline in percentage. And triglycerides will go down with any dose of LIRA, 0.65, 1.25, and 1.9. This is the dose that was studied before approval, which is similar to the 1.8 and 1.2 and 0.6 that we use. So PI1 also improves, minus 14, minus 29, minus 25. You get the maximum effect at the 1.2 dose. BNP decreases in all trials, and high sensitive CRP improves better by the dosing. The higher the dose, the lower the CRP. So this agent, in this case liraglutide, is a very good agent in improving lipids and decreasing inflammatory biomarkers. When compared with glibenclamide, known to us as glyburide, in the next slide, you're going to see that there is a difference on BNP, much better with LIRA 0.9 than with glyburide up to 2.5 milligrams, and free fatty acids change from baseline, much better with liraglutide than as a low dose of glibenclamide or glyburide. Next slide is sitagliptin and the effect on lipids. And as you can see, there's a slight increase in total cholesterol and LDL. There is also an increase of HDL that balances that increase in LDL. There's a nice decrease of triglycerides with the 25 and 50, and even though the increase is insignificant, there's a slight increase with a dose of 100. And again, free fatty acids will go down. Saxagliptin effect on lipids. Specific data were not provided in the published phase 3 trial. But when we look, there are modest numerical improvements from baseline to week 24 in total cholesterol, and that was demonstrated in the Saxa treatment group. There were no clear effects of saxagliptin on fasting lipid concentrations. The effect of linagliptin on lipids in patients at high risk for renal and cardiovascular disease. This is a post-hoc pool analysis of patients with type 2 diabetes with hypertension and microalbuminuria from 6 phase 3 linagliptin trials. The N is 512 patients. And as we see here, there's no significant difference in lipid changes from baseline for linagliptin versus placebo. So again, this agent appears to be okay in patients at high risk for renal or cardiovascular disease. Now we're moving into the effects of these agents on blood pressure and cardiovascular disease. Again, exenatide being the first GLP-1 in the market showed a nice improvement in both systolic and diastolic blood pressure, but there was no difference in patients reducing the number, type, or intensity of antihypertensive therapy. Next slide is liraglutide versus glimepiride, and you can see a nice reduction of blood pressure with the 1.2 and 1.8 compared with glimepiride. The reduction in systolic with glimepiride is 0.7, with lira 1.2, 2.1, and with lira 1.8 minus 3.6. And when we look at the placebo-adjusted mean change in systolic blood pressure, we see lowering between 5 and 8 millimeters of mercury. Now I'm going to show you the effect of DPP-4 inhibitor, linagliptin, on blood pressure in patients at high risk for renal and cardiovascular disease. And the most important thing is for these drugs not to increase blood pressure, but to decrease blood pressure. And you can see that compared with placebo, there's no significant difference, but both actually lower systolic and diastolic. In this case, linagliptin by 2.9 millimeters of mercury, the systolic, and 1.2 the diastolic, compared with placebo of 2.4 in the systolic and 1 in the diastolic. Again, these drugs appear to be very safe in this type of patients. We know that in the near future, you're going to see a lot of clinical trials long-term on cardiovascular safety. We already saw SAVOR and EXAMINE showing that DPP-4s do not increase the risk of cardiovascular deaths in patients that either were at high risk for cardiovascular disease or had a recent acute event. When we look at meta-analysis and pool analysis before approval, because all these drugs have to be approved based on a study that shows cardiovascular safety, exenatide BID, the risk ratio was 0.7, liraglutide 0.73, linagliptin 0.34, saxagliptin 0.43, sitagliptin 0.83, in general GLP-1 receptor agonists 0.78, and DPP-4 inhibitors 0.71. In the garden variety of type 2 diabetes enrolled in these clinical trials, the meta-analysis is very positive. But we need to wait for the final studies on each one of these drugs. Then this is the cardiovascular outcomes trials with incretin-based therapies. I told you that SAVOR TIMI-53 is completed and presented, and it doesn't increase cardiovascular events. The same is true with EXAMINE with allogliptin, completed, and it doesn't increase cardiovascular events. Both of the studies were with patients at high risk for cardiovascular events. TICOS is sitagliptin. Hopefully we're going to see this study in 2014 or early 2015. ELIXA is lixexenatide, a GLP-1 versus placebo in January 2015. LEADER, which is liraglutide, in 2015, late. EXCEL, which is exenatide, immediate release versus placebo in 2017. CARMELINA is Lina versus placebo in 2018. And CAROLINA, which is the only one with a comparator, linagliptin versus glimepiride in patients with type 2 diabetes with cardiovascular risk, also in September 2018. Then the data that these trials are going to give us is immense. Never before we have the opportunity to see data on cardiovascular events on any agent used to treat type 2 diabetes. I'm going now to tell you a little bit about SAVOR trial. Almost 16,500 patients with type 2 diabetes with established cardiovascular disease or multiple risk factors. They were randomized 1-to-1. Saxagliptin was used at 5 milligrams, except on patients with an eGFR of 50 or less, and the dose was 2.5. Other therapy at the physician discretion, so even though it's placebo, physicians were able to use other therapies except GLP-1s and DPP-4 to get to the target. But this is not a treat-to-target study. The primary endpoint is composite endpoint of cardiovascular death, non-fatal MI, or non-fatal fatal ischemic stroke. And as you can see, the primary endpoint is no difference, no increase in cardiovascular events with saxagliptin compared with placebo in a 2-year follow-up. In this slide, you see the EXAMINE trial. And the study design here is a lot less patients. Instead of almost 16,500, is one-third, 5,380. And these patients have a recent acute cardiovascular event. They were randomized 1-to-1 to allogliptin 5 milligrams 12.5 milligrams, or 6.2 based on renal function, plus standard of care. The primary endpoint was composite endpoint of cardiovascular death, non-fatal MI, or non-fatal stroke. And what we see here is no different than the previous study. In patients at high risk for cardiovascular events, there was no difference between placebo and alogliptin. That means that DPP-4s do not increase the incidence of cardiovascular death. I'm going here to show you the difference between SAVOR and EXAMINE. The planned duration for SAVOR was event-driven until the occurrence of 1,040 primary events. EXAMINE also event-driven with interim analysis after 80, 100, 125, up to 650 events for an average of 5 years. Analysis non-inferiority or superiority, prevention primary or secondary for SAVOR, secondary for EXAMINE, primary outcomes, efficacy and safety, time to confirm cardiovascular events, composite of death, non-fatal MI, non-fatal ischemic stroke for SAVOR, time to cardiovascular events, composite of cardiovascular death, non-fatal MI or non-fatal stroke for EXAMINE, and then the secondary outcomes, time to first occurrence of primary outcome, and all-cause mortality for SAVOR, and in EXAMINE, time to occurrence of any event in the secondary MACE composite of cardiovascular death, non-fatal MI, non-fatal stroke, and urgent revascularization for unstable angina. Now, the difference here is the key inclusion. In SAVOR, 40 and older. In EXAMINE, 18 and older. The A1C was similar, within 6 months. And in SAVOR, pre-existing cardiovascular disease or high risk for cardiovascular or multiple cardiovascular risk factors. Actually, the pre-existing cardiovascular disease was 80% versus 20% of high risk. In the EXAMINE, there were patients receiving monotherapy or combination, but they had an acute event. Exclusion for SAVOR, acute vascular events 2 months prior to randomizations, or treatment with a DPP-4 or GLP-1 within 6 months. In EXAMINE, the exclusion was type 1 diabetes, and treatment with a GLP-1 at screening, treatment with a DPP-4 within 3 months of screening, or more than 14 days total. And those are the difference. Now let's look at the difference in the active study. Remember, total 16,492 in SAVOR, total 5,380 in EXAMINE. Treated with Saxa, 8,280 in SAVOR, 2,700 in EXAMINE with alogliptin. Age, older in SAVOR by 4 years. Mean A1C, identical. BMI, higher in SAVOR, more U.S. population, even though the study was global. In EXAMINE, the population BMI is 28, is a significant difference. Mean duration, again, longer in SAVOR, shorter in EXAMINE. And the mean age was 65 for SAVOR, 61 for EXAMINE. Mean A1C, 8 and mean BMI. So you can see exactly the difference between the two trials. Now we're moving on safety of the renal impaired GLP-1 and DPP-4 inhibitors. This is what we need to do regarding dose titration. Exenatide, the recommended dose is 5 micrograms twice daily, and we increase to 10 based on clinical response, after 1 month. Dose adjustment for renal impaired, you need to use with caution when initiating or escalating doses, and is not recommended in patients with severe end-stage renal disease. Exenatide once weekly, the dose starts and continues to be the same, 2 milligrams once weekly, and is not recommended in severe end-stage renal disease, and you need to use it with caution in moderate ESRD. Liraglutide, 0.6 one daily for 1 week, then 1.2, and then you can increase it up to 1.8. This liraglutide dose adjustment is not necessary, but we recommend that when you do the adjustment, use with caution. The dose titration for renally impaired patients with alogliptin normally is 25 milligrams once daily. In moderate, you need to decrease it to 12.5, and in severe end-stage renal disease to 6.25 once daily. Linagliptin, 5 milligrams once daily, and the big advantage is no dose adjustment recommended. Saxa is 2.5 or 5 once daily, and you need to lower it to 2.5 in moderate or severe end-stage renal disease. Sitagliptin, you have to lower it from 100 to 50 in moderate, and from 100 to 25 or from 50 to 25 if there is severe end-stage renal disease. And vildagliptin, you lower the dose to once daily, so 50 BID is 50 once a day. In the linagliptin added to insulin, we also look at renal function at 24 weeks. This is a pre-specified subgroup analysis, and there was no significant interaction according to patient renal function category. The study had a high proportion of patients with renal impairment, and 60 to 90, 46.3 with Lina, 44.9 with placebo. Moderate 30 to below 60, 9.4 with Lina, 10.8 with placebo. And severe, 0.5 with Lina and 0.6 with placebo. And as I told you, there was no efficacy differences and no differences in safety as well. I'm moving now to the safety and tolerability of GLP-1 and DPP-4s. This is a summary of adverse effects of GLP-1 agonists and DPP-4 inhibitors. And as you can see, there is very few side effects with DPP-4 inhibitors, including aloe, lina, sita, and saxagliptin. The side effect difference is nausea and vomiting for exenatide, liraglutide, and exenatide once weekly. The longer acting, the less nausea and vomiting, but they still have symptoms. There's some side effects as diarrhea in lira and exenatide once weekly, very little with exenatide BID, and hypoglycemia only when combined with SUs or insulin. And as you saw, the study on linagliptin actually almost identical to placebo. And from all the trials from SAVOR and EXAMINE, we don't see really red flags for pancreatitis. So pancreatitis is rare, but you need to remember pancreatitis is more common in patients with type 2 diabetes. Summary: incretin-based therapies. And this is a meta-analysis from 2004, and obviously it doesn't include all the active GLP-1s and DPP-4s that we have together today in the market, but we see that there are more patients achieve the A1C of below 7 with GLP-1s than with DPP-4s, that there's a better reduction in A1C with a GLP-1 than a DPP-4, that is a better reduction in fasting with a GLP-1 than a DPP-4, and there is weight loss with a GLP-1 and neutral with a DPP-4. Then let's look at a meta-analysis again from 2012, and this is from Aroda in the clinical therapeutic, and this is the mean change from baseline of GLP-1 versus DPP-4. And again, in A1C for GLP-1 is 1.1 to 1.6, with DPP-4s 0.6 to 1. As far as fasting plasma glucose is minus 20 to minus 32 with GLP-1s, and minus 13 to minus 28 with DPP-4s. And the difference here in weight is usually the same, about 2 to 2.5 kilos for GLP-1s weight loss, and neutral for DPP-4s. This is a meta-analysis of 19 studies with exenatide BID, 10 with exenatide once weekly, and 11 with lira. DPP-4, 5 studies with aloe, 9 with lina, 7 with saxa, and 23 studies with sitagliptin, and 6 with vildagliptin. In summary, what you have seen before is a better lowering of A1C with GLP-1s, but significant lowering also with DPP-4. DPP-4s are oral, GLP-1 are injected. Weight effect is neutral with DPP-4. You see weight loss with GLP-1s. Common adverse events, occasional headaches and infections with DPP-4s. Nausea and vomiting with GLP-1s. rare serious adverse events, hypersensitivity, allergic reactions with DPP-4s, and GLP-1s, symptoms of pancreatitis that are questionable, low risk for hypoglycemia in both, GI adverse events only with GLP-1s, improved postprandial glucose with both. They're included in the algorithms of ACE and ADA, and that is true for both. Then, at the end of the day, there are benefits and advantages of incretin-based therapies. Both lower the A1C, the fasting, and the postprandial. There's weight neutral with DPP-4s. They do not promote weight gain. There's some satiety and weight loss with GLP-1s. There's beneficial on lipids on GLP-1s and beneficial effects on blood pressure with GLP-1s. The advantage of DPP-4s is most of them are once daily, at least in the U.S. They're orally, and they have minimal side effects, including GI. We're going to see more of this family of drugs. In the GLP-1 arena, we have albiglutide, lixexenatide, dulaglutide, and semaglutide in clinical trials. In DPP-4, I told you that Vilda is approved outside the U.S., but we have two other DPP-4 inhibitors in clinical trials, omaragliptin and selagliptin, so that the end is not yet here with us. In conclusion, incretin-based therapies are welcome additions for the treatment of type 2 diabetes. Both DPP-4 inhibitors and GLP-1 agonists improve glycemic control. GLP-1 agonists have beneficial effects on lipid, blood pressure, and weight. DPP-4 inhibitors are convenient because they're once daily oral administration with a very good safety and tolerability profile. The first two long-term trials with DPP-4 inhibitors, SAVOR and EXAMINE, show these therapies to be safe in patients with type 2 diabetes at high risk for cardiovascular disease. Thank you for joining us. I hope you will also participate in other courses offered in the diabetes curriculum. Have a good day.